This is the interventionist here. Once again, welcome back to the stream. This is actually a presentation done by our postgraduate resident. I found it pretty interesting and useful. I saw a lot of candidates who had joined in the last moment during the presentation. So I took the liberty of saving and recording the study by Dr. Kavya herself, and she had forwarded it to me. So I'm uploading this for all of you to understand the topic much better. So hopefully this is helpful for you. Once again, I thank all the participants and the organizing team, and especially the presenter, Dr. Kavya. Let's go to the...
Good evening, everyone. I'm going to talk about sonographic evaluation of placenta and its clinical importance. Placenta is a fetal organ of pregnancy. It is responsible for providing nutrition and oxygen to the fetus, as well as an excretory functions. Sonography remains the imaging modality of choice for evaluation of placenta. Placental abnormalities may cause major maternal and fetal complications. So timely recognition of these abnormalities will lead into the improvement in the management of pregnancy and delivery. Normally, the placenta is discoid in shape. The maternal side consists of decidua basalis, which opens into the intervillous space. The fetal side consists of the chorionic plate and the chorionic villi. The fetal villi consists of cytotrophoblast, syncytiotropoblast, and the fetal vessels, which is pooled or immersed in the maternal blood in the intervillous space. The anchoring villi extends from the chorionic plate and it gets attached to the decidua basalis, which helps to hold the placenta in position. The flow in the intervillous space is usually detected after 12 weeks of pregnancy. If the flow is detected before 12 weeks of pregnancy, it will indicate a failed pregnancy. Normally, the placental thickness will increase as the gestation advances. As a general rule, the placental thickness should follow the gestational age in weeks. For example, in a 20 weeks placenta, it should measure 20 mm, whereas 30 weeks placenta should measure 30 mm. In general, the placenta measurement should not go above 40 mm. Placentomegaly is seen in case of macrosomia, Beckwith-Wiedemann syndrome, or in case of any obesity. And thin placenta can be seen in IUGR or in aneuploidy. So placental thickness is very much important. Placental maturation. Overall appearance of placenta also will change during the course of pregnancy with progressive development of calcification. As the gestation increases, the amount of calcification will also increase. Granum classification is given for the grading system of placenta based on its maturity. There are 4 gradings available. Grade 0 is seen less than 18 weeks of gestation, where there will be uniform echogenicity without any calcification. As it progresses to grade 1, in 18 to 29 weeks, few occasional parenchymal calcifications are seen. In grade 2, 30 to 38 weeks, there will be occasional basal calcification. In grade 3, which is seen most commonly more than 39 weeks of gestation, there will be significant basal plate calcification. So as the pregnancy advances, the amount of calcification increases in the placenta. The first trimester placenta, there will be an initial focal thickening at the site of the gestational sac attachment. The normal fetus will be covered by the amnion and chorion, and the amnion and the chorion will fuse only after 14 weeks of gestation. Before 14 weeks of gestation, amnion will not fuse with chorion, and the yolk sac will be seen between the amnion and the chorion. This is a ultrasound image showing a second trimester placenta, which is homogeneous and with uniform echogenicity. There is a hypoechoic subplacental lakes between the placenta and the myometrium. The exact location of the placenta along with the placental relationship with the internal os should be documented in case of second trimester. Third trimester placenta is heterogeneous in ecotexture. There is diffuse calcification will be seen. After 30 weeks, the basal calcification and the cotyledon calcification is considered to be a normal finding. The normal placental location and its relationship with the internal os should be documented in third trimester. Color Doppler should be used to rule out any blood vessel at the level of the internal os to rule out vasa previa. Coming to variants of placenta, succintorate lobe refers to an accessory small additional lobe separate from the main placental lobe. There will be retention of this lobe and it will lead to postpartum hemorrhage. Bilobed placenta is nothing but two equal-sized placenta attached by a thin placental tissue. Here also the placenta one lobe of placenta may be retained and may result in a postpartum hemorrhage. So in case of bilobed placenta, we'll have two equal-sized lobes, whereas in succintorate lobe, there will be one main bulk of placenta with another small accessory lobe. The cord will usually be attached to the main placental bulk. In bilobed placenta, the cord usually attaches to the center of the central placental tissue, which connects both equal-sized lobes. Coming to circumvallate placenta, in circumvallate placenta, the edges will be rolled out and it is inserted inwards from the corner of the edge. So the edges will be thick and irregular and it will be seen as folded or rolled up edges. It will lead to abruption and hemorrhage. Placenta membranacea is a thin membrane covering circumferentially the entire placenta. This may cause placenta previa as it may cover the internal os. Coming to pathologies of placenta, placental abruption. Placental abruption or abruptio placenta refers to the premature separation of the placenta after 20 weeks of gestation and before third stage of labor. Normally in placenta, there will be trophoblastic invasion of spiral arteries. In preeclampsia or in case of any maternal trauma or in case of any smoking, there will be abnormal trophoblastic invasion of the spiral arteries, which will lead to rupture of the spiral arteries and it will result in premature separation of placenta. Ultrasound is used for classification of the location of the Ultrasound classification is based on the location of the hematoma. It can be marginal abruption or retroplacental abruption or a preplacental abruption. Marginal abruption, the hematoma will be seen at the edge of the placenta. In retroplacental abruption, the hematoma will lie between the placenta and the uterine wall. In preplacental abruption, the hematoma is seen between the placenta and the membrane. Appearance of the placenta depends on the age and size of the hematoma. In case of acute hematoma, it will be isoechoic to placenta. In subacute, it will be heterogeneous or hypoechoic. In chronic or resolving hematoma, the blood will liquefy and it will approach sonolucency. Here is an ultrasound image showing a large hematoma which is almost isoechoic to placenta. It is seen at the margin or edge of the anterior placenta. Here, this ultrasound image showing a hypoechoic hematoma beneath the placenta, suggestive of retroplacental abruption. Preplacental, this is an ultrasound image showing the hematoma on the fetal side of the placenta, suggestive of a preplacental abruption. The preplacental abruption is a rare one. It may occur along with the retroplacental abruption or a marginal abruption. Once a patient presents with a vaginal bleeding or a tender uterus, we have to look for abruption and once the patient presents with a vaginal bleeding or a tender uterus, we have to look for abruption and previa in all the second and third trimester cases. We have to evaluate for the fetal heart rate at the beginning of the scan because fetal bradycardia will lead to emergency delivery of the fetus. The management of small abruption is usually conservative. Serial sonological examination with measurement of retroplacental clot volume, antepartum heart rate, and maternal symptoms have been suggested. Coming to subchorionic hemorrhage. Subchorionic hemorrhage is nothing but a crescentric collection of blood between the uterine wall and the chorionic membrane. It is a frequent cause of first and second trimester bleeding. Fetal outcome depends on the size of the hematoma. The size of the hematoma is normally compared with the size of the gestational sac. If the size of the hematoma is less than 20% of size of the gestational sac, it is considered to be a small hematoma. If it is 20 to 50% of the size of the gestational sac, it is a medium-sized hematoma. If it is more than 50%, then it is considered to be a large-sized hematoma. If the amount of hematoma is about 30 ml, it would result in 50% of fetal demise. If it is more than 60%, if it is more than 60 ml, then there will be confirmed 90% of fetal demise. So the fetal outcome depends on the size of the hematoma. If the collection is seen to extend into the internal os and it causes expansion of the internal os, it will result in a poor fetal outcome. Coming to placenta previa. Placenta previa refers to abnormal implantation of the placenta in the lower uterine segment. It is the most common cause of antepartum hemorrhage. Normally, the relationship of the placenta to the internal os will change as the pregnancy advances, as the uterus enlarges. The diagnosis should not be made before 20 weeks of gestation and should be evaluated later in gestation because the size of as the uterus enlarges, the location of the placenta varies. This is an image showing a normal placenta. The edge of the placental margin is more than 2 centimeters from the internal os. If the edge of the placenta occurs 2.5 to 2 centimeters from the internal os, it is known as low-lying placenta. If the edge of the placenta occurs at the margin of the internal os, it is known as marginal placenta previa. If the edge of the placenta partially covers the internal os, it is known as partial placenta previa. If the placenta covers the entire internal os, it is known as complete placenta previa. This is an ultrasound image showing a normal placenta in which the edge of the margin of the placenta is more than 2 centimeters from the internal os. It is an ultrasound image showing a low-lying placenta where the edge of the placenta is 0.7 centimeters from the internal os, which is considered to be a low-lying placenta. Here it is an ultrasound image showing the edge of the placenta occurring at the margin of the internal os. So it is a marginal placenta previa. Here in this image, the placenta almost covers the entire internal os. So it is a complete placenta previa. There is a new revised classification which contains only 3 categories in which placenta previa depicts the placenta covering the internal os. Whereas low-lying placenta is the one where the placental edge is less than 2 centimeters from the internal os. If the placental edge is more than 2 centimeters from the internal os, it is considered to be normal. Differential diagnosis is full bladder, focal myometrial contraction. Transvaginal ultrasound is essential for the diagnosis. Normally, more than 90% of second trimester low-lying placenta and placenta previa will resolve. Follow-up should be done at 32 weeks for an asymptomatic placenta previa or a low-lying placenta which is diagnosed in second trimester. Further follow-up should be done at 32 weeks once if a 32-week scan is abnormal. Further follow-up should be done at 36 weeks. Earlier follow-up is necessary if it is symptomatic. Vasa previa is the presence of abnormal fetal vessel within the amniotic membrane and it crosses the internal cervical os. It is unsupported by the Wharton's jelly and it is more prone for rupture, which causes a fetal hemorrhage. Doppler is necessary to prove that it is a vessel is of fetal origin and it is not of a maternal origin. There are 2 types of vasa previa. Type 1 is velamentous cord insertion and type 2 is subcenturate lobe or a bilobed placenta. More than 90% of vasa previa is associated with a low-lying placenta. If we have a variant placental morphology, then vasa previa should be ruled out. This is type 1 vasa previa, which is due to a velamentous cord insertion. Here is an image showing a normal umbilical cord insertion into the center of the placenta. Here, it is a velamentous cord insertion, that is, umbilical cord is inserted into the chorioamniotic membrane outside the placenta and it is not supported by the Wharton's jelly. When this exposed is type 1 vasa previa in which there is velamentous cord insertion. Here, the cord is inserted into the chorioamniotic membrane outside the placenta, and this is known as filamentous cord insertion. This exposed blood vessel is seen in front of the internal os, and it is more common for rupture, and it will lead to hemorrhage. Mangrove sign is common, which is nothing but a large branching vessels immediately at the site of insertion, like the exposed roots of a mangrove tree. Type 2 vasa previa, in which there is which is associated with accentuate or bilobed placenta, in which the fetal blood vessel, which connects both the lobes of placenta, lies at the margin of the internal os. So it can be an asymptomatic presentation without any symptoms, or a symptomatic presentation which presents with bradycardia or heart deceleration. As with placenta previa, vasa previa also is diagnosed in second trimester, and it should be re-evaluated later in gestation. The differential diagnoses are marginal sinus previa, where prominent maternal vessels are seen at the edge of the placenta. Chorioamniotic separation, where there will be linear sonolucency near the os without any flow. Marginal placental abruption, where the blood at the os may mimic placenta or the vessels. Coming to morbidly adherent placenta. Placenta accreta is the one in which the placenta is attached to the myometrium. Placenta increta is the one in which the placenta invades the myometrium. Placenta percreta, in which the placenta penetrates the myometrium and involves the adjacent structures. Here, the ultrasound image showing a placental bulge, and there is loss of normal clear zone. And there is a myometrial thinning of less than 1 mm. There will be abnormal placental lacunae. Presence of numerous lacunae, including some of them that are large and irregular. There is bladder wall interruption. There is interruption of a bright bladder wall. Hyperechoic band is being interrupted. There is an intraplacental hypervascularity. Ultrasound scoring system for evaluation of suspected morbidly adherent placenta shows 4 gradings, whereas grade 0 is normal placentation. Grade 1 is there will be less than 1 number of lacunae and less than 1 centimeters of loss of clear zone. In grade 3, there will be bladder interface interruption. This is an image showing placenta accreta, where the placenta is being attached to the myometrium. There is normal loss of hypoechoic zone of myometrium, and there is thinning of myometrium. This is an image showing the placenta is being invading the myometrium. Ultrasound image showing the penetration of the placenta into the adjacent parametrium. Placental lakes are nothing but formation of hypoechoic cystic spaces within the placenta. It results from a perivillous fibrin deposition with cystic change. It contains only maternal blood. Multiple lesions are common. It is surrounded by a normal placenta. Normally, the lesions should not be more than 5 centimeters and more than 3 lucency. And if the lesion is seen less than 25 weeks, the placental lake should be followed up. Take-home message. The exact location of the placental implantation and its relationship to the os should be documented and reported in second trimester, and it should be assessed in every scan. The diagnosis of placenta previa should not be made before 20 weeks, as the relationship between the placenta changes when the uterus enlarges, and it should be followed up at 32 weeks. If a 32-week scan is abnormal, it should be repeated at 36 weeks. Vasa previa need to be excluded in patient with a variant placental morphology like a bilobe placenta or a accentuate placenta. Vasa previa should be excluded. 90% of vasa previa is associated with a low-lying placenta. High risk of suspicion of morbidly adherent placenta should be suspected because in a case of a pre or cesarean section or in case of a placenta previa. Any hypoechoic mass in a placenta, color Doppler is essential to rule out the placental chorioangioma.